Good afternoon, everyone. I'm Mi-kyung CHUNG from Seoul Nature Fertility Center. It is my great pleasure to hear as a speaker at prestigious meeting. In my presentation today, I would like to review with you the clinical utility of molecular assessments for finding the appropriate endometrial status. The previous speaker spoke detail on the history of endometrial method and a large number of appreciated cases. So I will explain that part briefly. Korea has not yet applied a large number of errors, and EMMA and ALICE are the early stage of introduction. Therefore, it is difficult to explain clearly step by step, because there is not much data. So today I will only share initial experience. There is no disclosure related to the presentation. Overall, I will explain is the step by step by dividing it into description of endometrial receptivity, application of endometrial receptivity analysis for diagnosis, 3, clinical outcome of personalized embryo transfer, and 4, discussion of future directions. Implantation failure occurs during, depending on the quality of oocyte, sperm, and embryo, and selection of oocytes. And following the 6 factors that act as maternal factors, recently studies on the state of endometrium and immunological studies have been actively conducted. To overcome such implantation failure, the importance of overall health of endometrium has recently been studied extensively. In particular, we are comprehensively evaluating the endometrial asynchrony, abnormal endometrial growth, endometrial microbiome, and the chronic endometriosis and abnormal endometrial growth. We will look at these today. During the window of implantation, the blastocyst can attach to the endometrial epithelial cells and invade the endometrial stroma and vasculature. The process can only occur when endometrium is receptive. An understanding of the window of implantation is necessary to form endometrial asynchrony. The WI is characterized by the presence of Pinopodes in the 1960s. After that, histological studies reported that the out-of-phase status in 25 of infertile patients. In general, it has been reported that pinopodes appear more rapidly than in natural cycle. In these cases of controlled ovarian stimulation, since then, various studies have also described the development of advanced endometrium. Endometrial receptivity is the ability of endometrium to successfully attach to the blastocyst. And it is a complex process in which the structure of endometrium is changed, and the substance is expressed and secreted change dramatically. Luminal epithelial expression of critical receptor, granular epithelial development and secretion, stromal decidualization, and angiogenesis and immune modulation are important processes. The synchrony between the embryo and endometrium that occur during the process is an important indicator for implantation. And poor synchronization leads to increase in the pregnancy rate and an increase in the miscarriage rate. Furthermore, it acts an important factor inducing infertility accompanied by placental insufficiency. To find the endometrial asynchrony, to prevent such implantation failure and accompanying infertility, molecular analysis of RNA and secret protein and secretome microbiome is being actively conducted beyond the existing histological studies. Histological studies have been traditionally used extensively and is currently used representatively, but it has been reported that the correlation with the infertility status is low and the histological dating is not a valid method for diagnosing luteal phase deficiency. As shown in this table and figure, it is difficult to distinguish between fertile and infertile patient cases when a randomized controlled study is conducted on out-of-phase patients. Pinopode scores were low in patients who failed definitively after Pinopode evaluation, and there was an increase in pregnancy rates when individuality was performed based on the criterion. However, this method is difficult to apply rapid ER confirmation because it is complicated to prepare and confirm. In a series of studies, it has been reported that endometrial receptivity is difficult to form with endometrial thickness. Using the developing Omics tool, studies on genes related to endometrium have been actively conducted over the course of the 2000s. Recently, as shown in two studies, single level of analysis have allowed us to interlocate endometrial signaling at unprecedented resolution, unraveling the molecular network driving receptivity and identifying key WI biomarker genes. Customized diagnosis based on transcriptomic signature analysis and bioinformative prediction according to endometrial dating became possible. The menstrual cycle was confirmed through ERA diagnosis and divided into 4 stages. As a result of sampling, about 40% of cases with WOI shift were transported, and it was reported that the rate was high in patients with RIF and higher BMI. Most people are interested in consistency of ERA in the paper of the left. When repeated in the same patient, the same result was maintained even after 2 years. And when the pregnancy result on the right was confirmed, the same condition was maintained. Recently, it is said that the ERA result, which has been tested once, can be used to determine the timing of implantation for up to 3 years. When personalized ET was performed based on these ERA tests, it was confirmed that clinical and ongoing pregnancy was higher than of standard transfer. And when euploid embryo were used, it was not statistically significant, but it tended to show high clinical results. Given these results, a 5-year multicenter randomized controlled trial was conducted, and PT, FET, and fresh embryo transfer did not show statistical significance in the first transfer cycle, but the PT led to statistically significant higher pregnancy rate in 1-year cumulative pregnancy results. The previous speaker have already explained the parts on examining and applying ERA in detail, so I will skip this part. In Korea, there are not many cases, but 44% of cases showed a receptive pace, which is somewhat lower than other previous reports, although the number of patients was small. Post-receptive was relatively higher in natural cases, and pre-receptive was higher in HRT cases. In cases of patients in our hospital, about 58% were receptive, and although it is difficult to distinguish clearly due to the small number of patients, there were many post-receptive cases in natural cycle. Let me tell you about our center's overall data. We tested a total 67 patients with average 39.3 years, and many of them also underwent histological dating. ERA results were analyzed according to the age, BMI, and number of implantation failure and endometrial thickness. Personal ET was performed on patients who had blastocyst and cleavage stage embryo transferred. Clinical outcomes were analyzed according to endometrial stage and embryo stage. The results show difference according to the age. The data on the left is for whole of Korea, and data on the right is from the later fertility center. There is no significant difference between the groups. Although it is not statistically significant when comparing the older age group and younger group, it shows a relatively high tendency to be receptive pace. When checked the number of implantation failure, we did not see much difference in our data, but the Korean data was found that percentage of the receptive phases significantly decreased in patients with more than 7 repeated failures. We analyzed according to BMI. There was no significant difference in our patients. On the day of biopsy, there was almost no difference in endometrial thickness. Histological dating showed about 61% of cases were receptive pace between POD 3 to 6 days, and there are many late receptive cases in early dating. This slide shows the clinical outcome of after PT in our hospital. Of the 67 patients tested for ERA and 67 patients transfers, mean age is 39.2 years were performed in 50 patients, and total 22 were pregnant. Clinical pregnancy was 32.8%. First, a total of 21 blastocysts transferred, and 19 receptive cases were transferred, and 10 cases, 52.6% became pregnant. In non-receptive cases transferred, 8 cases presented 62.5% pregnant, showing good clinical results for patients who experienced many failures. When blastocyst transfer was checked according to the developmental stage of embryos, the implantation rate of hatching and hatched embryos was high as 73% based on the results. It seems more appropriate to transfer a more developed embryo to appropriate receptive pacing. When cleavage embryos were transferred, the overall pregnancy rate is very low, but 35 cases were transferred resulted in a total of 7 pregnancies. When divided into under the over 40-year-old, there was no significant difference when cleavage stage embryos were transferred, but blastocysts showed higher pregnancy rate those under 40 years old. There was a statistically significant difference between the two groups in implantation rate. When analyzing 3 or more repeated failure patients, non-repeated failure patient group performed that among the patients who underwent PET, the pregnancy rate was high and implantation rate was statistically significantly higher in repeated implantation failure. When blastocyst was transferred and analyzed according to ERA and histology, there was no significant differences in NR and R in both groups. There were 20 patients in Korea who underwent and the second biopsy, and 4 cases in our hospital. Among them, post-receptive patients performed the second biopsy, adjusted the time, and gave birth after transfers. Korea has not yet introduced Emma and Alice in earnest. The explanation of the 2 analyses was explained so well by Dr. Lee above, so I will omit the description of the method and effect and share the initial data on 24 Koreans. Emma was performed on 24 patients. The number of patients who underwent Emma was divided by age on the left and the number of implantation failure on the right, but the sample was too small to tell the results. In our hospital, 6 out of 10 patients showed normal finding, and 1 patient had abnormal findings. In 24 patients who underwent Alice, the left side was divided according to the age, and the right side was divided according to the number of implantation failures. So no special analysis was possible. Our hospital had negative results in all 10 patients. After the endometrial was performed, our patients, 1 patient was treated in our hospital with abnormalities. After antibiotics and probiotics treatment, the pregnancy was accomplished and maintained. Now I would like to summarize our results. First, non-receptive ERA patients have displayed WI and personalized embryo transfer improves clinical results. Second, the rate of pregnancy in RIP patients with a receptive ERA is comparable to that in general ALT population. Third, hatched and hatching blastocyst shows a significantly higher implantation rate. Fourth, transfer at cleavage stage shows low clinical outcome. Thus, more preparation are still needed. I'd like to summarize what I had in mind while applying clinically to ERA. As a result of a comparative study of the gene group classified by biopsy according to patient's menstrual cycle in our hospital several years ago, with the genes published earlier in the Simon group, we found that 167 genes matched the data of Simon group, and various inconsistent genes were identified. Also, the gene introduced into the ERA is not an embryo-induced derived gene. It seems that more research is needed on genes related to new regulations, such as considering immune response or the involvement of exosomes. In addition, I think it would be good if the non-coding RNA results, which our group has been collecting little by little since 2019, can also be applied to diagnosis. In 2015, our laboratory reported to ASRM that HCG-infused endometrium showed a radically different gene expression pattern. Therefore, it would be good if studies on gene expression pattern changed by intrauterine infusion of HCG, endometrial regeneration for thin endometrium, were applied in combination. Overall, I would like to continue with the following additional discussions. One, the need of a variable number of genes with the embryonal induced effect. Two, the need for additional application using various non-coding RNAs. Three, the need for a model for 3-day transfer to meet the increasing number of advanced age patients. Four, the need for model for fresh case transfer. Five, the need for detailed biopsy model for patients with narrow receptive pace. Six, the acquisition of extended genetic information for regenerated endometrium of HCG-infused endometrium. In addition to current application of endometrium, it is hoped that the following discussion will take place so that ERA itself will be applied to more detailed parts so that more patients do not fail implantation. Thank you for your attention. Thank you.
Thank you, Dr. Chung, for your presentation. Because of the time, I will only ask you one question, which was the first question that we received. I will read the question as it was written. Here we go. Which cleavage state patient applied the ERA test?
In cleavage stage, in Korea, advanced ages were gradually increased. In our hospital, we performed on patients of advanced age and the poor responder, and the patients who did not perform blastocyst during the previous cycles. I think the cleavage stage transfer is not proper and not recommended in the Igenomix, but their patients, they are no option for overcome this repeated failure. I know the cleavage stage patients are the main factor is the embryo quality, but our data shows 7 patients were overcome the repeated implantation failure. So in my discussion, narrow stage for the 3-day is the proper for 3-day ET. Yeah. If I want to, the model is needed. Okay.
Yes, okay. All right. Thank you very much for answering the question and for your presentation.